All right, guys, so today I'm going to be talking about tuberculosis. And tuberculosis is caused by what we call Mycobacterium tuberculosis. So I'm just going to put it right here in parentheses, Mycobacterium. And so tuberculosis, TB, is a very aggressive, a highly aggressive bacteria that's highly communicable for those people who are susceptible. So we're talking about people who live in dense population groups, like people who are immigrants who are coming in dense population groups, people who are in jail or prison who are densely populated, and people who are immunocompromised. You guys got to remember, your immune system is pretty healthy and can do a lot of different things if you're healthy. And so generally speaking, people that develop tuberculosis active infection, it happens because they have some type of susceptibilities. They either are already sick with something else, they have HIV/AIDS, or they have some type of immunological issue where they are highly susceptible to developing these type of infections. So let's start off by discussing how do we detect it, okay? So generally speaking, the first thing that you want to do to find out if somebody has tuberculosis is you do a Montauk test, right? Or you do a PPD. And the PPD is done intradermally. You give them 0.1 mLs of the PPD, of the partial plasma derivative, and you will see a little wheel. So for a PPD, you assess it 48 to 72 hours afterwards, and you're looking for something called induration. For those of you that speak Spanish, duro is hardening, right? So induration, we're talking about the texture of the skin at the site of the PPD. It changes. Sometimes the nurses don't even look at it. They just run their finger across the wrist, the forearm, to see if they can feel the induration. And so what we're looking for 48 to 72 hours after the PPD intradermal injection is for induration. And if it's 10 millimeters or more, that's considered positive for tuberculosis. Now, that does not mean that you have tuberculosis. That just means that you have the antibodies that attacked that PPD, that protein of tuberculosis, inside of the arm, and that's why it reacted. That's why it became indurated. Keep in mind that if you're assessing TB on a patient who is already, if you're assessing for TB for a patient who is already immunocompromised, then for them, 5 millimeters or more is considered a positive reading. Again, I want to emphasize, this does not mean that the patient has active tuberculosis. It just means that the patient has been exposed at some point, but they have the antibodies for that particular tuberculosis mycobacterium, right? Now, once that's positive, then we do the next step in the determination whether the patient has active tuberculosis or not. We do what we call a chest x-ray. And when we're doing a chest x-ray, you educate the patient that anytime they're going to have an x-ray, they're going to be sitting in a hard table and they're going to be assuming a variety of positions, and you educate the patient about that. The patient should not be pregnant, by the way, right? So when you're doing a chest x-ray, you have to educate the patient that we're looking for infiltrates. Well, maybe you don't have to tell the patient that, but you as a nurse, you have to know that, guys. Infiltrates is something that we see in the image that's not supposed to be there. Okay, now I know that we're not experts in assessing chest x-ray film, but you have to understand the theoretical principles. And what we're looking for is something called infiltrates. And that's something inside the chest x-ray film that's not supposed to be there. Now, does that mean that they are positive for active tuberculosis? Not necessarily. It could be scar tissue from the coronavirus that you had last year, because a lot of people are developing scar tissue after the infection, right? It could be a tumor. It could be a variety of things. That's not necessarily tuberculosis. So because of that, once they test positive for infiltrates, that there's something inside the chest x-ray film, then we move on to the definitive diagnostic tool, which is the sputum culture. Now, the sputum culture, you get it early in the morning. The patient should not be brushing their teeth before that, should not be eating anything for breakfast before that, and they should get it early in the morning. And the sputum culture is known as an acid-fast bacillus test, an AFB test. And this is the type of sputum culture that we're gathering from the patient. And if they have 3 positive tests, subsequent tests, then that now confirms tuberculosis and you actively have tuberculosis. At that point, you have to consider the following. since this patient with this bacterial infection that we know is airborne, whoops, well, we have to place them on specific type of isolation, and that isolation is known as negative pressure room or negative pressure isolation. And what negative pressure isolation is talking about is when that patient's in their room, they usually have some type of filter on the window that sucks all the particles from within the room out to the window. So what I want to emphasize is this: negative pressure room is sucking everything inside the room. That's what I want you guys to think of. Negative is sucking everything inside the room, because every time I or every time the particles disseminate throughout the room, we don't want those particles to be creeping out and infecting other people. So the room is negatively pressurized, and it's sucking everything inside the room through the HEPA filter that filters out all the particles of the tuberculosis mycobacterium, and it neutralizes them so no one else will get infected. Okay, that's your negative pressure room. When you as a nurse, you go into that patient's room, it's going to be hard for you to open that door because it's sucking everything inside. Okay, so make sure you don't confuse that with positive pressure rooms, which is used for immunocompromised patients. Okay, but let's go back to the whole negative pressure room thing for tuberculosis or any condition that's potentially highly infectious to other people. Well, we want to protect the public, so we have a negative pressure room. At the same time, the nurse has to wear a particulate mask, and we call those the N95 masks. I'm sure everyone's familiar with the N95 masks. And as you know, the N95 masks are fitted for your particular facial contours. They normally put a little helmet when you put the mask on. There's small, medium, large. I'm sure there's extra large too. And you put it on, you make sure it's on your face, and you put a little helmet on, and there's a little opening in the helmet, a little plastic helmet. It's big, by the way, and they spray like a citrusy spray that mimics the size of the particles that are being expectorated or that are being spread about when you have tuberculosis. They're the same size. So if you're wearing the mask and if you can smell it or you can taste it, then that means that mask is not fitting well, because those particles can seep through. And that's what's supposed to happen when you wear an N95 mask. You have to have it specially fitted for your facial contours. Now, if the patient is going to be transported outside the room for whatever procedure, maybe they have to go to the x-ray department because they don't have a portable x-ray machine, then what we do is we slap on a regular surgical mask for the patient, because a surgical mask stops any of the secretions that are being sneezed out right here. So we don't really have to worry about them going anywhere else because they're being stopped right here. And statistically speaking, it reduces the likelihood of those particles traveling elsewhere. So remember, if the patient's being removed outside into another location, you slap on a surgical mask for them. And this is what's happening when your patient has tuberculosis. Keep in mind that the signs and symptoms are pretty significant. The main ones that you really want to focus on are hemoptysis. And so hemoptysis is referring to coughing up bloody sputum. Keep in mind that the patient will also have night sweats. Okay, they'll have night sweats. The patient will also develop anorexia and weight loss. Any patient that has an infection is going to have the same type of symptoms. Pyrexia, high fever, coughing, they're going to have malaise. But to be specific, when somebody has tuberculosis, they're going to have hemoptysis, coughing up of bloody tin sputum, because the bacteria is really aggressive and it's destroying the tissue, the parenchyma of the lungs. You'll have night sweats and you'll have weight loss. And those are the main clinical manifestations for people that have tuberculosis. In regards to the medical regimen, you guys got to keep a few things in mind. Let me erase some of these things so I can have more room. The medications that we use for this aggressive bacteria, Mycobacterium tuberculosis, the antibiotics are also aggressive antibiotics. So we're talking about isoniazid or INH. Keep in mind that we give this medication for patients who have also just been exposed. For instance, if I'm the patient and I've tested positive for active tuberculosis, but I've been hanging out with my girlfriend and her family the whole time, well then now whoever I'm living with, my girlfriend and her family, or whoever I'm living with, then all of them have been exposed. So we give them isoniazid prophylactically because it's been shown to decrease the bacterial load, and it reduces the likelihood of the family members or those who have been exposed to actually develop the active tuberculosis. We also can give rifampin. So rifampin is also a very highly aggressive antibiotic, and keep in mind that these medications, rifampin, it turns your bodily fluids orange. So you want to educate your patient about that, because if not, they're going to be tinkling and they're going to see that it's chromy orange, and that's going to be a potential distressing situation. So you educate them that it's expected. And then another drug that we give is known as ethambutol. Okay, these are your first line antibiotic therapies for patients with tuberculosis. Okay, keep in mind that all of these drugs are going to be taken for a long period of time, at least 6 months. So the book says 6 to 9 month antibiotic therapy. That's how long these patients are going to be taking these drugs for. We keep them on rotation to ensure that the patient does not develop resistance to it. And keep in mind that since all drug metabolites are broken down by the liver and excreted by the kidneys, well then we have to assess kidney and liver function to ensure that there's no detrimental effects of the long-term antibiotic therapy that this patient is going to be taking. So we assess kidney and liver function. Okay, and sometimes when the patient develops other secondary issues because of toxicity of the drug, they can develop neurological issues like optic neuritis. So keep in mind that you guys review the specific side effects and the specific organs that these medications are going to be affected, so you know what particular lab results to be assessing for. For liver, it's going to be your liver enzymes, your alkaline phosphatase, and for your kidney function, it's going to be your BUN and your creatinine. Those are the serum levels. Okay, folks,